Our next speaker is Rachel Ruddy, who is a consultant psychiatrist based here in Jersey. Thank you.
Good evening. I'm speaking on behalf of Our Duty of Care Jersey, which is a group of healthcare professionals in Jersey who would say assisted suicide and euthanasia are not healthcare. The current proposals in the States Assembly run counter to our actions as healthcare professionals. We console, reassure, and support many in desperate situations. Patients are often weary, distressed, and depressed, but these are not reasons to help them die, but reasons to affirm their value, their worth, and their intrinsic dignity. We understand those who call for euthanasia, that they do it from compassionate motives, but we fear that there are unintended consequences for all of us. I'm going to address 4 questions. Is assisted dying what Jersey really wants? Is an assisted dying service the best use of Jersey's limited healthcare resources? Can we actually get assessment for assisted dying right here? And what do we really want our society in Jersey to look like? So firstly, are we clear assisted dying is what the whole of Jersey wants? We certainly can't be sure through our electoral process, as people in Jersey do not vote. We are the lowest voting nation of all the nations reviewed by the Organisation for Economic Cooperation and Development. The citizens' jury was stacked in favour of assisted dying at the beginning of the process. The Doctors' Island survey only had responses from a quarter of the island's doctors, and only about 5 doctors were strongly in favour. And even if Jersey was in favour when this process started, we have to look up and look around and learn from other nations, like Canada, where these things are going badly wrong. Many commentators who were pro are backtracking. I'm going to read you something else from that same article that William read from at the beginning, from the Guardian writer. As a Liberal, assisted dying is something I feel instinctively in favour of, but stories emerging from Canada have prompted me to think again. Worrying stories have emerged that hint at a lack of safeguards. Relatives shocked at doctors' lack of probing of family members who have pursued voluntary euthanasia. The process of proactively suggesting to veterans that this would be good treatment, including Christine Gauthier, a former Paralympian who had been trying for 5 years to get the government to install a wheelchair ramp. A man with significant disabilities who testified to the Canadian Parliament that nurses tried to coerce him into medically assisted dying by threatening to forcibly discharge him without care and denying him food and water for days. Other commentary is also showing a darker side to this euthanasia debate, one that saves the government money. One assisted suicide costs approximately the same as 2 weeks of nursing home care. Secondly, is assisted dying the best use of Jersey's healthcare resources? We are short of general practitioners, hospital medical staff, nurses, care home workers, and the shortage in the care sector means that patients are remaining in hospital much longer than they should because there is no care package or 24/7 facility to support them on discharge. In the face of long hospital stays, people may feel despondent, lacking value, not wanting to put on relatives, and this does make them very vulnerable to suggestions of assisted dying. Healthcare and social care have also got to focus significant time and attention into making changes in the light of the clinical governance review at the General Hospital and other scrutiny reports looking at things like maternity, mental health services and safeguarding. On a positive note, Jersey is working on loads of really important strategies to improve healthcare on the island. This is really exciting work, and I am really privileged to sit on a forum where I get to hear about some of this. In an island where a woman has to wait 18 months for a mammogram and other screening for cancer is equally backward, I am really encouraged to see things moving forward. But we are only just beginning some of this work, and we are beginning to look at a much-needed dementia strategy. Once the strategies are determined, these things will cost money to implement. In the face of so much necessary work about improving the lives and the healthcare outcomes of islanders, should we really be investing time and money into a service to end lives? Thirdly, I wonder if we can really get assessment right. You've heard a lot about this already. So a key part of understanding someone's views is being able to assess their capacity to make a decision. Jersey mental capacity legislation only came in 2018. There is no mandatory training for staff. We are behind on assessments doing even the basic work of this law, and there is certainly no training to detect coercion in decision making. Baroness Finlay has talked about how elder abuse is so prevalent, yet I don't think we're detecting this all of the time in our services. And can we really assess a wish to die? As a psychiatrist, I know it's terribly hard to predict when someone is suicidal whether they will take their own life or not. In assisted dying, it is equally hard to know how settled this wish is, especially when the proposed Route 1 gives 14 days from decision to death. A wish to die is influenced by so many things, as we've heard about: depression, fear, loneliness, pain, fatigue. And who does actually understand what happens when you die? It can be something we're terribly afraid of if we're not educated. We know that the treatment of depression, even in someone with a terminal condition, can reverse a wish to die, as we've heard about, and improve quality of life. But what we know from other countries where this is in practice is that people are not assessed for depression, that depression is not spotted and treated by assessors, and we are left wondering whether a different decision would have been made. And I wonder whether we can have the confidence it will be spotted here in Jersey. Good assessment and treatment depends on relationships. And in this graph, looking at assisted deaths in Oregon, we see that people took much longer to make a decision to die when they had a good relationship with the person who was doing the assessment. In the proposed service in Jersey, they will not know the doctor doing the assessment. Will sufficient time and relationship be built to form that proper assessment? Finally, I want to ask what we want our society in Jersey to look like, because changing healthcare into something that can provide death will fundamentally affect it. There are many people in Jersey who are struggling. 1 in 4 children in Jersey live in poverty, and the cost of living is rising. Are we really going to fund a free assisted dying service when someone with healthcare needs cannot access a GP for free? When people travelling off-island for treatment can't afford to take a family member with them? When the recovery from interventions might result in family members having to take time off work and lose salary to care for them? The Jersey Mental Health Profile was published in December 22, and this showed that 14% of adults living here in the island are lonely. 1 in 10 don't feel their life is worthwhile. And this increased in those who hardly ever saw people outside their home, had bad health, and were poor. These are all risk factors in choosing assisted dying. Jersey has a great capacity for neighbourliness. We've seen this in the recent tragic events that have happened. Let's look at how we can change our society to become more compassionate, to make life better for people, especially the old, the frail, the disabled and the ill, rather than expose them to a choice that makes them more vulnerable. As part of our consideration of Jersey society, we also need to think about the many people who work in health and social care, and be aware that the decision to introduce assisted dying has a psychological impact on people working in these services. Where assisted dying is legal, healthcare practitioners are struggling with capacity assessments, with guilt about their role in the process, and some are experiencing pressure to make decisions that they don't agree with. I want to end by saying suicide or euthanasia is never the right option. The lack of safeguards presented in the current proposal are like an accessibility ramp to the vulnerable in Jersey society. In Jersey, we have so many better options to try to improve our healthcare, to improve our society, and to show value to our staff. Jersey is not the right place. This is not the right time to see this change in the law. And if you're in agreement with this and you work in health or social care, please sign our letter on our webpage to show your support.